round. It's a fairly kind of round shape, but as you work your way distally in the humerus, you'll see that it fans out. And it has these sharp edges. It's quite sharp. They call these supracondylar ridges. So you have a lateral and a medial supracondylar ridge. And as the name implies, they precede, they're above, they're above these condyles. Okay, so we see the condyles here. We'll also see epicondyles. So you have a lateral epicondyle, which is a little less pronounced. We can see it here on the posterior side, lateral epicondyle. And then there's a medial epicondyle, which comparatively is quite pronounced. And you can palpate your medial epicondyle there fairly easily. Okay. We'll also see a couple of other features on the humerus. Two fossa. So there's a radial fossa and a coronoid fossa. And these fossae will accommodate these structures down here on these bones, so the head of the radius and the coronoid process of the ulna. And whenever you go into flexion, these pokey parts need somewhere to go, so they just kind of occupy these little pockets. Now the condylar surface, when you hear condylar surface, they're normally talking about some sort of contact surface on bones. So this is the surface of a bone that's usually pretty smooth. It's going to make contact with another bone. It's covered in a hyaline cartilage, so it's kind of slippery and hopefully not bone on bone. And we can see that in the humerus, don't know why, but they name these condylar surfaces. Okay, so here and here. So capitulum, this is called the capitulum. Got labeled on the next slide. Actually, got a label on this slide. So capitulum and the trochlea. So the capitulum is just this spherical little thing here on the lateral side of the distal humerus. And then the trochlea is here. The trochlea is Latin, means pulley. So it's kind of shaped like a pulley that you would wrap a rope around or something like that. You can kind of see that indentation there on the inside of it. All right, good. On the back side of the humerus, which is occupied here by this feature, we see an olecranon fossa. So like we have a coronoid fossa and a radial fossa. On the back of the humerus is an olecranon fossa. And naturally, the olecranon or the olecranon process of the ulna will sit down inside of that fossa. And the olecranon process is extremely easy to palpate. You're probably most familiar with your olecranon process when it comes to your elbow joint. It's the one that's dead center, right in the back. Like if you were to elbow drop somebody, that's what you would hope to hit them with, right? So it's like the pokiest part. If you go medial to the olecranon process, you get to the medial epicondyle. So that's what you're feeling out there. Lateral epicondyle, you can palpate. It's just less pronounced than the medial epicondyle. So olecranon process, kind of large and in charge. And if you recall from the last lecture, we talked about the triceps. So the triceps muscle will come down like this and insert right onto that olecranon process. So whenever you fire your triceps muscle, it's going to pull that olecranon process and pull your forearm into extension. Okay, so other features we can see on the radius has this rounded head. So head of the radius and the neck of the radius. Those are kind of reasonable names. So head and neck of the radius. And then on the front, remember this is the anterior side of the radius, we see a very notable bump. This is the radial tuberosity. Again, maybe a term we remember from last time, the radial tuberosity is the primary insertion site for biceps brachii. Biceps brachii. Over here on the ulna, we see the coronoid process, which remember in flexion of the elbow would occupy the coronoid fossa. It kind of slides along the trochlea there. And then just distal to that, we see an ulnar tuberosity. So radial tuberosity on the radius, insertion of biceps brachii. Ulnar tuberosity on the ulna, insertion of brachialis muscle. So the brachialis muscle, recall, is one of the three muscles in the anterior arm, so elbow flexor. All right, so a lateral and a medial view. So this is a medial view, so this is like an inside-out view. I can see the medial epicondyle. I see the kind of the sharpness of the edge of the supracondylar ridge, so the medial supracondylar ridge. From a lateral view, I see lateral supracondylar ridge. So you kind of get a sense of how they sit in relationship to each other. So nothing new on this slide, just different views. With the elbow inflection here from the medial view, and the elbow inflection from the lateral view. There is a joint that's formed proximally between the radius and the ulna. Okay, so the head of the radius, okay, will fit right here into the radial notch. So if you were to look at just the bare ulna, if I go back, you can see like there would be like a little notch in here, radial notch. So the head of the radius would articulate right in that radial notch. And this forms a fairly stable joint. So the proximal radial-ulnar joint. It's a good name for it. It's just talking about the two bones that are articulated together. Okay, so whenever our elbow goes into flexion, a lot of the action that's happening is the security of the joint, if you will, is happening right here between the ulna and the humerus. Okay, so you can see that deep sort of groove there, it's the trochlear groove, okay, or trochlear notch. We got to be able to pick these out on radiograph. So I'll show you AP, so this is an anterior posterior radiograph, and then a lateral. You can kind of see a little bit, a few different features here. And remember, all of this is superimposed, so the supracondylar ridges are easy to see, so lateral, medial, supracondylar ridges. Remember, you can follow those down. You'll see some epicondyles. So lateral epicondyle is not too big, really. Medial epicondyle is quite a bit bigger. Radial head and neck are quite easy to see. The bumpiness of the radial tuberosity is easy to see on an AP X-ray. So if you had, for example, an avulsion fracture, which I don't think I've talked about yet, then you could probably detect that from this view. An avulsion fracture is whenever a muscle, usually a muscle that's attached to a skeletal insertion site, rips the bone off. So essentially, an avulsion of the radial tuberosity will be your biceps just getting so aggressive and pulling so hard that it would pull the radial tuberosity off of the radius. So in imaging or an MRI, you can just see the biceps muscle with a chunk of the radial tuberosity just floating around, free agent. So avulsion fractures are common issues in musculoskeletal anatomy. Ulnar tuberosity, I mean, the bumpiness and the rippliness of the ulnar tuberosity is kind of difficult to see because it doesn't have much of a shape to it. The ulnar tuberosity is less of a bump, more just kind of a rigid, ripply kind of surface, more similar to the deltoid tuberosity. We can note where the capitulum would be here, and we can see where the trochlea is at. We can estimate those smooth surfaces as well. Now the olecranon is hiding back there, right? So the olecranon process kind of gets superimposed onto all of this close to the midline. So if you had a lateral view, you could assess the health of the olecranon a little bit better. This is also a better place to get the ulnar tuberosity. So ulnar tuberosity would be kind of right there. So if you had a brachialis avulsion, you would see that from the lateral view. Okay, so working our way down. So we talked a lot about the proximal features of the radius and the ulna. There's that radial notch that I mentioned. Let's work our way down the bones a little bit. So the bones are approximated by this interosseous membrane. So there's a thick, it's just brilliant white membrane. You can see it whenever you're dissecting, just shiny, just really bright. And it's a type of joint technically, and it keeps these bones stuck together. Okay, so the interosseous membrane will stick together along these sharp ridges along the radius and the ulna. Okay. So if we follow these distally then, so if we follow, this is an anterior view of the radius over here on the left, if I follow it down like this is what the radius would look like if your palm is facing up like this. So distally I can see the radius's shaft is getting wider and wider and wider, and it will terminate out here laterally at a styloid. So the radial styloid, the styloid process of the radius is this pokey one. It is most lateral on the distal radius, okay, and it's easy to feel your styloid process up there on your radius. So the distal radius and lateral. Similarly, the ulna also has, like the radius, an interosseous border, and that's where that interosseous membrane attaches. If we follow the ulna down, we see the head of the ulna is distal. So remember, the head of the radius is proximal, and the head of the ulna is actually distal. And the ulna, like the radius, has a styloid. So there's an ulnar styloid as well. Okay. Also feature that we like in anatomy on the back of the radius, this is the posterior side of the radius. We can see the radial styloid here, no problem. But we also see an extra little bump here called Lister's tubercle, or the dorsal tubercle of the radius. And Lister's tubercle is interesting because it acts as like a little pulley. So you'll have a tendon that we'll talk about later that will wrap around Lister's tubercle like this and go toward your thumb. So it acts like a little pulley. And you can feel Lister's tubercle. So this is supinated, right? Supination versus pronation. So in supination versus pronation, the radius is doing all the lifting. I mean, the ulna pops out a little bit, but radius is really what's doing all the lifting. So where this is the front of my radius, if I go into pronation like this is the back of the radius. And I can feel Lister's tubercle. like a bump there on the back of your radius, and that's where the EPL tendon will wrap around, acting kind of like a pulley. All right, so adding a little bit of meat to the bones, we'll talk about the actual joint of the elbow. So the elbow joint is a synovial joint, like the shoulder joint. And remember, the scheme for synovial joints is to have a fibrous capsule, which is there's thick fibers connecting the bones together, and lining the inside of the capsule, remember, is a synovial membrane. And the synovial membrane is, so the cells, the synoviocytes in there, there's producing synovial fluid, so it's bathing all of the contact surfaces in this lubricant. And that's what you see right here. So Netter is a nice illustration of this, where in the picture he's just cut open the fibrous joint capsule and the synovial capsule as well. And you can see that. So all this on the inside here would be lined with synovium with the exception of the contact surfaces. And this is where, if you were to poke in there, if you poke into somebody's joint like this, all the synovial fluid just leaks out in this thick, viscous sort of material. Posteriorly here, I can see the olecranon. There's the olecranon process, and just a view inside of the joint capsule. Now, in the shoulder we had capsular ligaments, and in the elbow we have capsular ligaments. So very, very common, very important. So shoulder, elbow, hip. So very, very important ligaments that we have here. These ligaments are not like their own independent band. Remember, it's not like you have the joint capsule and there's some thick band over the top of it. When we say capsular ligaments, we're talking about thickenings of the actual fibrous joint capsule, and that's similar to what you see here in the elbow. So if you were to rip off all the muscles around the elbow, which is it's difficult to do, so all the muscles coming from the medial lateral epicondyles, if you scrape them all away, it does look something about like this. So you see this fibrous joint capsule on the outside, and I see two notable thickenings. One on the lateral side, called the radial collateral ligament. That makes sense. Radial side, thumb side, lateral side. So on the lateral side, we have the radial collateral ligament. And on the medial side, we have the ulnar collateral ligament. These are just thickenings of the fibrous joint capsule. One other one is, you'll see, I think I have a better picture of it on the next slide, is the radial collateral ligament will have a little extension that comes away, and it sort of envelops the head of the radius, just like this, and it sort of tightens around the head of the radius. So over on this side, you can see RCL, so radial collateral ligament coming down, and this band of fibrous tissue surrounding the head of the radius is called the annular ligament. So annular, going around the head of the radius, and it keeps the head of the radius intact. Keeps it stuck and approximated to the joint surface. So the top of the head of the radius has this kind of dip to it like this, so that when you go into flexion like that, that dip just rolls along the capitulum of the humerus. But you want to keep it approximated. If the head of the radius were to pop out, you would have a bad time. And this happens. So this popping out, this is a very frequently board-tested sort of thing. Very common to see, is called nursemaid's elbow. So nursemaid elbow is your patient profile is usually a younger person, obviously like a kid or something like that. And kids joints and ligaments, they're really like lubed up, and they're very, very loose. Okay, their ligaments are very, very lax naturally, and they've become less lax over time. So they tend to be a little bit more flexible at most of their joints. Even their tendons are a little bit more mobile. And because of that, if you ever seen anybody, like, it's a good thing, I guess, like parents together, whatever, like grabbing their kids by the arms, swinging them kind of like this. Have you seen this? So this is like how they always write the test questions. They're just like trying to pick the kid up by their arms like this, swinging them around. And you shouldn't do that. You shouldn't do that because they can sublux and eventually dislocate the radial head. Essentially, you're just pulling the radial head right out of the annular ligament. And the patient will present with pain and usually deformity in the area. I like Netter's plate here, this like sad kid with his teddy bear. And so usually like a painful kind of swelling here on the lateral side of the elbow, right? And a clinician would be able to palpate the deformity. Yep.
So could this happen if they were just like playing on the playground too, or like holding like
Yeah, traction. Yeah, so any kind of like traction related injuries. It's normally like a sudden kind of pull. That's how they bake it into test questions. So it could be like in some sort of like discipline scenario. You're at the grocery store, like, what are you doing? Like, you want to do this to your kids? Maybe I don't have kids, but you know what I mean? So if it's a sudden like sudden traction or pulling like that would like jerk the radius and challenge the annular ligament suddenly. Does that make sense?
Yeah, so is there like a safe age that you could pull up?
Well, I mean, technically we're all subject to nursemaid's elbow. It's just the kids are more subject to it because of the natural laxity in their ligaments. So I don't know what the American College of Pediatricians says about this, but I mean, it's just a risk that you would take, I guess. You just need to be careful about how quickly and how suddenly you would start pulling their arms. And I mean, some kids I'm sure are more susceptible than others, but a very, very common MSK injury in kids. And it can work its way out. So it may be, this is subclinical, meaning they may not have any clinical symptoms at this point, where it's just pulling down that annular ligament a little bit until the point that it's totally dislocated, so out and away from its position, and that gives you that deformity on the outside. Cool. Another important elbow clinical correlate here is UCL reconstruction. So everyone's probably familiar with this if you follow baseball. It's called Tommy John surgery. So the ulnar collateral ligament on the medial side of the elbow here is going to provide strength to the joint space between the humerus and the ulna. And that joint space, particularly medially, is challenged during overhand pitching. So if you're pitching overhand like this, you can see that, well, this is not the greatest picture because his arm's kind of moving forward at this point, but if you watch them when they take a stride off the mound like this, their hand will come this way, like their elbow is moving faster than their wrist, right? This kind of helps with the slinging action. So their elbow is coming forward like this, they're challenging that UCL, they're pulling their humerus and their ulna apart there medially. And you do this enough, you could tear the ulnar collateral ligament. So very common, very, very common in pitchers, overhand pitchers. And so what they like to do is just go in there and fix it. They'll use some sort of graft. There's a muscle in your forearm that we'll talk about today called palmaris longus. Sometimes we'll use that, and a couple of muscles in the leg that are also frequently used to harvest for ACL repair. So we have a couple of muscles. They'll just go in there, they'll take a strip of a little muscle away, and that's what they use to fix it. Cool. Okay, a little bit more anatomy at the elbow. So we're starting to put a little bit of meat on here. There's an important location between the olecranon. So what I'm touching right here is olecranon. So if this is olecranon, then what is this muscle? What is this muscle? If this is olecranon, what is this? This triceps. This triceps. This is the back side. So posterior side. So remember olecranon on the posterior side, triceps back here coming down and inserting onto olecranon. Over here is medial epicondyle. So there's the medial epicondyle. Now there's an important space between there, and I invite you to palpate yourself here carefully. It's kind of uncomfortable. This is called the cubital tunnel. So there's a space in here. It's tight, man. Whenever you're dissecting through here, it's very, very tight. There's no daylight in here at all. Importantly, there's a small artery in there, the posterior ulnar recurrent artery, and there's a pretty chunky nerve in there, the ulnar nerve. The ulnar nerve is pretty good size. So if you're a good sized person, then it's about as big as a pencil. You know, if you're a little bit bigger than average. So it's a serious nerve, and you can feel the passage of the cubital tunnel simply by running your fingers in the groove between the medial epicondyle and the olecranon process. So cubital tunnel, an important little area there. So of the nerves that are important in the forearm and hand, the ulnar nerve is certainly one of them. It's the ulnar nerve, only the ulnar nerve that is a derivative of the brachial plexus, actually passing posterior to the elbow joint. So ultimately, the ones we haven't talked about in as much detail, the radial nerve, the median nerve, musculocutaneous nerves, derivatives, all those are passing in the front of the elbow joint, whereas the ulnar nerve passes behind the elbow joint in that cubital tunnel. And it would enter into the flexor compartment of the forearm. So this is an intraoperative image of a cubital tunnel release. So very, very common orthopedic complaint here. So this is the medial epicondyle. Right there's the medial epicondyle. I can see they've spared some little local muscular branches going into some of the little muscles nearby. And the surgeon would just dissect this free. So it's not a terribly big exposure. And the cubital tunnel is right in here. That's right where the cubital tunnel is located, right in there. Okay, ulnar nerve entrapment. So knowing what we know about the ulnar nerve from last time, so the ulnar nerve would has some sensory innervation down in the hand, right? So we talked about some of the sensory innervation of the ulnar nerve being the medial side of the hand, so the front and back, medial side of the hand, 5th digit, and then half of the 4th digit. So the medial side of the 4th digit. Okay, so people with cubital tunnel entrapments, a lot of times they'll complain of a sensory deficit or some sort of paresthesia in this area, pins and needles, something like that. All right, good. So we're just layering more stuff on. So we mentioned these veins already, so these are not new, but I'll mention them again. There's, you can see that our forearm is just littered with veins. And these veins that we see, remember, they're in the superficial fascia. They're in the superficial fascia. You can see they do not have arteries that are paired with them. We talk about muscles, we're talking about stuff deep to the deep fascia. And in the arm, we call it the brachial fascia. And in the forearm, we call it the antebrachial fascia, which makes sense. So remember, if you peel someone's skin off, there's going to be a lot of fat and a lot of veins and maybe some superficial nerves in there. If you keep peeling, you're going to get to this tight, thick fascia. That's the brachial or the antebrachial fascia. Muscles are down inside. So between that deep fascia and the skin, running through the superficial fascia, which is mostly fat, we see these veins. And as you can see on the person here, there's a lot of them. You can look at your own arm and see there's a lot of them in there. The two big ones that we want to keep up with are the ones on the lateral side here, the cephalic vein, and the one on the medial side here, the basilic vein. So these are players we've discussed before. And recall there's a connection between the cephalic and the basilic vein called the median cubital vein. So superimposed on a person here, we can see their basilic and their cephalic kind of coming down, making almost like a H pattern, like the letter H, and then the median cubital vein there in between. So median cubital vein, really any of these veins they can target for venipuncture in the cubital fossa. So a couple of important nerves that we'll see in the cubital fossa. One is the lateral antebrachial cutaneous nerve, or the lateral cutaneous nerve of the forearm. So this lateral antebrachial cutaneous nerve is an extension of the musculocutaneous we discussed last time. And it's going to be sensory only to the skin. So the lateral antebrachial cutaneous nerve is popping out, okay, just lateral to the biceps tendon. It goes into the superficial fascia where the fat is, and it just plugs into all your skin running on the lateral forearm. Okay, so lateral forearm, lateral antebrachial cutaneous nerve. The medial forearm, medial antebrachial cutaneous nerve. So the medial antebrachial cutaneous nerve tends to be buddies with the basilic vein. So I see basilic here. And of course, this is going to do skin on the medial forearm. Okay, so if you draw the brachial plexus, you may remember the medial cutaneous nerve of the forearm, or the medial antebrachial cutaneous is a branch of the medial cord. Medial cord. So it all kind of, with the upper extremity, it all kind of comes back to the brachial plexus. If you're doing the brachial plexus well, then you're doing pretty well all the way down into the hand, as you'll see. Okay, so very important slide. I would definitely know this one. So anytime an anatomist gives you borders and contents, there's going to be a test question on the borders and contents. You got to know borders and contents. This is our job. We have to make sure that that in OMS 1 year that students know about all of this stuff. That way, when they get into surgery rotations or become surgeons, they know what to expect in certain exposures. So the cubital fossa, very important little fossa. It's like your elbow pit, kind of like you have an armpit. Okay, there's a little elbow pit here. This is the cubital fossa. So we got to know the stuff inside the cubital fossa and its boundaries. So on the medial side of the cubital fossa, I'll see a muscle that we'll discuss in just a minute called pronator teres. You can probably guess the action of pronator teres, right? Pronator. So that's the medial boundary. The lateral boundary is a muscle called brachioradialis. So there's brachioradialis. And then the superior boundary is just an imaginary line drawn through the epicondyle. So I can see ghosted in back there is the humerus, right? So the superior border there is an imaginary line through the epicondyle. So that gives us a triangle, okay, a little triangle shape. The floor of the cubital fossa is primarily the brachialis tendon. Okay, Okay, so primarily the brachialis tendon. And what I would like you to know is the contents. Okay, so you got to know the borders, you got to know the contents. So the contents of the cubital fossa from lateral to medial, remember tendon, artery, nerve. You got to know this from lateral to medial, biceps tendon, brachial artery, median nerve. Biceps tendon, brachial artery, median nerve, from lateral to medial. Okay, so if you have a patient presents with some sort of, after a car accident, they have a chunk of glass in their cubital fossa, which of the following nerves most likely affected? As a clinical thinker, you'd be thinking, all right, well, I know the median nerve's in there. If the median nerve is in there, what muscles are going to be affected, which means which actions are going to be affected. I also know the median nerve has a sensory role. Remember, median is money. From last time, median is money. So they have a sensory deficit along that line. Okay, borders and contents, cubital fossa. All right, so let's talk about the blood supply. So we mentioned the brachial artery last time. Artery formerly known as the axillary artery, travels through your armpit. So the axillary artery, remember, changes names to the brachial artery at the inferior border of teres major. So it's just one blood tube, just heading down. The axillary artery, with the brachial artery, continues down, 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 down. It doesn't go too far until it gives off this branch, the deep artery of the arm, or profunda brachii. So deep artery of the arm, or profunda brachii. It wraps around the back of the humerus, close to the mid shaft. And recall, this is a content of the triangle interval. So a lot of this stuff is kind of interconnected. If you got a mid-shaft fracture of the humerus, you're worried about the profunda brachii artery and the other content of the triangle interval, which is the radial nerve. All right, the brachial artery continues down, and it won't wait too long until it gives off two little collateral branches. Okay, so the first collateral branch is called the superior ulnar collateral. And if we go a little bit lower, we'll see inferior ulnar collateral. And you're like, well, what are these for? So these superior and inferior ulnar collateral arteries help with what's called the elbow anastomosis. So wherever we have joints, if our joint is capable of a big range of motion, like our elbow or our knee, if we were to pinch off, for example, the elbow, if we're in some sort of like flexion like this nonstop, or our knee, for example, and you were to crimp off the blood supply that's passing distal to that joint, then you're gonna start to develop issues. You're gonna start to develop problems because your tissues are not being perfused distally. So we get around this by forming what's called anastomoses. Anastomosis is just like a connection. So like tubes that are kind of connecting around the joint. So this is what we do, and these are very small. They're quite small. They're much lower caliber than the brachial artery. So the superior ulnar collateral coming down, inferior ulnar collateral also branching off the brachial artery. And we can see the brachial artery at this point passing through the cubital fossa. So remember, T-A-N, tan. This is the A in tan, and it bifurcates into the radial artery, which goes lateral, and the ulnar artery, which goes medial. So radial artery, lateral side, ulnar artery, medial side. Off of the ulnar artery, we'll see an anterior ulnar recurrent and a posterior ulnar recurrent. So I've kind of crudely illustrated them over here on this side about how they connect. So remember, the anterior ulnar recurrent will anastomose with the inferior ulnar collateral. And then the posterior ulnar recurrent will anastomose with the superior ulnar collateral. And this happens behind the elbow in the cubital fossa, or cubital tunnel. So the good way to remember this is the vowels go with the vowels and the consonants with the consonants. So I, inferior ulnar collateral, goes with A, anterior ulnar recurrent. S, superior ulnar collateral, goes with P, posterior ulnar recurrent. The name recurrent here just referring to it's coming back. It's recurring from where it came from. And then famously off of the radial artery, we'll see a branch that crosses over the tendon of the biceps and recurs. So this is just one single radial recurrent artery. And the radial recurrent artery will anastomose with the radial collateral artery. The radial collateral artery in most people is a derivative of the deep artery of the arm. So we can kind of see it go down like this and just become radial collateral. So these collaterals and recurrents forming these anastomotic connections around the elbow So if we have a suboptimal blood supply in the brachial artery because it's pinched off for whatever reason, then we're able to get blood past the joint. We can get blood past the joint and via these anastomotic connections to keep our tissues perfused distally. Okay. Good. So elbow anastomosis. All right, so let's talk about the actions at the wrist. So the actions at the wrist joint. I'll point out a few things here. So in the wrist we have, when we're thinking about the wrist, we're basically thinking about connections between the radius and 2 of the 8 bones that we have in our hand, in our proximal hand here, called carpal bones. So the radius here distally is articulating with 2 of those 8 carpal bones here. And at that joint is where most of this action is occurring. So with the wrist, we call this flexion and extension. So you can see here in the image. So extension of the wrist, okay, just moving back, flexion of the wrist moving forward like this. So flexion, extension. So most of that's happening at that joint between the carpal bones and the radius. So this is this joint here, radiocarpal articulation, just a fancy pants name for it. Other actions at the wrist joint, so we can see some of those carpal bones here. So more on those carpal bones later. You'll get to know these pretty well. For now, they're a bit of a mystery. Extending away from the carpal bones, we have metacarpals. So we have 5 digits, so we have 5 metacarpals. They're just numbered 1 through 5. So metacarpal 1, 2, 3, 4, 5. With number 1 being the thumb and number 5 being the pinky. So digit 1 is your thumb and digit 5 is your pinky. Distal to these metacarpals, we see your finger bones. And 4 out of the 5 digits that you have in your hand have 3 phalanges. You have a proximal phalanx, which articulates directly with that metacarpal, forming the MCP joint, the metacarpophalangeal joint. From the proximal phalanx, we see another articulation to the middle phalanx. And between them, we see the PIP, or the proximal interphalangeal joint. And then we see a distal phalanx. The distal phalanx articulating with the middle phalanx to make a dip, or a distal interphalangeal joint. So on you, then, your carpal bones are mostly like right about here. They're just kind of down in here. Your metacarpals emanate away from them. And then your metacarpals, remember they're numbered 1 through 5, start articulating with your finger bones. So the proximal phalanx would be here, intermediate or middle, and then all the way in your fingertip would be your distal phalanx. So if you flex your MCP joints, you're flexing where you would call your knuckles. So this is flexion at the MCP joint, extension at the MCP joint. And then you can see in most of your fingers, except, well, all of your fingers, most of your digits except for the thumb, you have 2 more joints, right? There's a proximal interphalangeal joint and then a distal interphalangeal joint. In your thumb, there's just one big joint, right? So the MCP joint for the thumb is right here. And then there's just one, they call it an interphalangeal joint. There's just one for your thumb. So you have a proximal and a distal phalanx for your thumb only. There's no middle phalanx in your thumb. This is important because the way these muscles insert and act on your fingers can be very clinically informative a lot of times. So getting familiar with the name schemes, MCP, PIP, DIP, will be useful. One other action we can see at the wrist joint is a side-to-side action. So we mentioned on the wrist, we see a flexion and extension. We can also see a deviation. So if I'm in an anatomical position like this, I can adduct and abduct, like going away. They also call this ulnar and radial deviation. Almost like these bones are sort of rocking side to side. So if you're like waving like this is like ulnar and radial deviation. So if you're going toward the radial side, this is radial deviation or abduction. Toward the ulnar side, okay, this is adduction. Humans are pretty good ulnar deviators. So the thought behind this is that we're, like the evolutionary thought behind this is that it helps us whenever we're grabbing something to hit things. So if you were to swing a baseball bat, you wouldn't swing a baseball bat with like your wrist straight like this, would you? So if you were to swing a baseball bat, ultimately you're going to go into this ulnar deviation kind of position because it would maximize the amount of force that you could produce at the end. So it's kind of the just so story in anthropology, but people think that, you know, we were just bashing each other to pieces, I guess, throughout evolutionary time, and that's why we developed such great ulnar deviation. just low yield for board exams, just stuff I like to talk about. Okay, so let's move into the anterior compartment of the forearm. Let's talk about some of these muscles. So, like I said, lots of muscles in the forearm, a lot of muscles in the forearm. And the nice thing about them is that they're kind of broken up in such a way that they're grouped either functionally or by their nerve or by their origin. So if you pick up on some of these trends, it makes it a little easier pill to swallow. So follow with me now. Muscles of the anterior compartment of the forearm are largely associated with the medial epicondyle. So if I feel over here on the medial epicondyle, there's like a wad of muscles that you can palpate just distal to that, which is overwhelmingly a lot of the muscles that we'll be talking about now. When I think about muscles of the anterior forearm, I'm thinking about muscles which generally help flex the wrist and flex the digits. So flexion of the wrist, flexion of the digits, and a little bit of pronation. Okay, when I think anterior compartment muscles, I'm thinking muscles generally that will be flexing the wrist, flexing the digits, and maybe a little bit of pronation, right? Pronation going down like that. And they're broken up into 3 layers. So you have a superficial, an intermediate, and a deep layer for the 8 muscles in the anterior forearm. A good way to remember this, there's 4 muscles in the superficial layer, 1 in the intermediate, and then 3 in the deep layer. So 4 minus 1 is 3. This helps you remember how many is in each layer. And these muscles are sort of covered by what's called the biceps aponeurosis or the bicipital aponeurosis. So remember, when biceps is coming down, it has an insertion onto the radial tuberosity, and it has this fanning sort of pseudo attachment here called the biceps aponeurosis. So if you want to dissect these away, we usually just cut to the biceps aponeurosis so we can get to the muscles. Okay. All right, so we'll start from the medial epicondyle, and we'll do the first 4 here. We'll look at the superficial layer, which has 4 muscles. So the first muscle that we see here is pronator teres. So the pronator teres associated largely with the medial epicondyle, a little bit of the ulna, and inserting over here onto the radius. So here is pronator teres. This is an anterior view of the forearm. If I were to shorten this muscle, then the radius is going to get pulled kind of like that. So it's going to pull the radius over such that the palm of your hand goes down like that. So that's a good name for it then, pronator teres. There's 2 muscles that we use to pronate. One pronator teres I just mentioned, and then distally, the pronator quadratus, which I'll mention in just a bit. Okay, so pronator teres, medial epicondyle, pronation. You notice a lot of these are innervated by the median nerve, not all, but most of them innervated by the median nerve. So median nerve, content of the cubital fossa. Working my way down from pronator teres in this common flexor origin, I see flexor carpi radialis. So it's a pretty good name for it. So it's going to be a wrist flexor on the radial side. So it's going to flex carpi, meaning wrist. Okay, so flexor carpi radialis coming from that medial epicondyle down toward the base of the second metacarpal, and it's going to help with wrist flexion and a little bit of abduction. Remember, abduction is like radial deviation like that. Okay, but primarily wrist flexor, innervated by the median nerve. I can also see another muscle coming from the medial epicondyle. So medial epicondyle, right? It's important for these. I see the palmaris longus muscle. So the palmaris longus muscle coming down the forearm. It's got a long tendon with a little belly. Now the muscle belly on this, the artist is taking a little bit, I would say too much liberty. It's never this big. But it's got a skinny little tendon that will come all the way down. It jumps very superficially into this fan of connective tissue called the palmar aponeurosis here in the palm of your hand. So you can see my hand here. You can test to see if you have a palmaris longus by trying to touch your thumb and your pinky together and then flexing a little bit. So you can see on me, I've got a tendon that pops up. So that tendon that pops up is the palmaris longus muscle. It likes to pop up because it's jumping over the carpal tunnel, whereas many of these are bubbled down to the carpal tunnel. Okay, so there's palmaris longus. If I look lateral to palmaris longus, I'll see the flexor carpi radialis tendon. So that's it right there. So there's flexor carpi radialis tendon. Remember that guy? I just mentioned it. And if you look lateral to that, all right, so it went palmaris longus, lateral to that, flexor carpi radialis tendon, lateral to that, that's where you'd feel a radial pulse. So if you have a difficult time feeling a radial pulse, you can find that flexor carpi radialis tendon and roll your fingers just lateral to that. Everyone has flexor carpi radialis. Not everyone has palmaris longus. Kind of interesting. Cool. Palmaris longus, remember we mentioned in Tommy John surgery, it may be a favorite for them to use for UCL repair. All right, and then last but not least, so I mentioned here, look, pronator teres, flexor carpi radialis, palmaris longus. I'm going to skip this one because it's in the next layer. And I go all the way to the ulnar side, or the medial side. This is flexor carpi ulnaris. That's a good name for it. So we saw flexor carpi radialis on the radial side, flexor carpi ulnaris on the ulnar side. So also associated with the medial epicondyle primarily. Coming down, usually a bifurcating kind of attachment to the base of the fifth metacarpal, and also inserting into the pisiform, forming what's called the piezohamate ligament. So flexor carpi ulnaris. The flexor carpi ulnaris is a little bit of an outlier among the ones I've mentioned in that it's innervated by the ulnar nerve. And it does have two little heads. I mean, so technically a little bit of it's attaching to the ulna here. It's not all medial epicondyle. So whenever the ulnar nerve, remember, is running through the cubital tunnel, it likes to tuck itself in between the two heads of flexor carpi ulnaris. And so then it makes sense that it would then innervate it. You can feel it most medially, so it's difficult to get a border on it, but it would just be the most medial muscle here. Your ulnar nerve runs right underneath it, all the way down. It's tucked in there. So the ulnar nerve right underneath it. FCU, flexor carpi ulnaris. So flexor carpi ulnaris, as the name implies, these names are very forgiving. So it's going to flex the wrist, kind of like flexor carpi radialis. So if I fire flexor carpi ulnaris and flexor carpi radialis together, I'm going to get wrist flexion like this, okay? If I fire one or the other, I'm going to get a little more radial or ulnar deviation, okay? If I don't want my wrist to flex straight down like this, if I want a little more deviation, I would maybe use one or the other. Okay, so this is a table that you're familiar with, so I've just given you the all of the muscles in summary here, so nothing extra, just a nice summary table. A good way to remember these in the superficial compartment is the memory device pass, fail, pass, fail. So starting from medial epicondyle coming down, here I see pass P, starts with a P, there's pronator teres. Coming down, now starting with an F toward the base of the second metacarpal, sometimes the third, flexor carpi radialis, fail. P, palmaris longus, pass. And then F, flexor carpi ulnaris, fail. So pass, fail, pass, fail. Also note, look at this, I mean all of them, with the exception of one, innervated by the median nerve. So when I'm thinking superficial compartment in the anterior forearm, I'm generally thinking median nerve. I just remember one exception here, the ulnar. And then all of them have maybe some subtle attachments here and there, but all of them have at least here some commonality with the medial epicondyle, right? Cool, not too bad. So now we move, remember 4 minus 1 is 3. So 4 in the superficial compartment minus 1 equals 3 in the deep compartment. So the single muscle I see in the intermediate compartment, the middle compartment, there's just one, is the flexor digitorum superficialis. So in this picture, what the artist has done is they've taken away the 4 muscles that were in the superficial layer. So pronator teres is gone, flexor carpi radialis is gone, all that's gone. And I can see flexor digitorum superficialis now, the single muscle in the intermediate compartment. And you kind of look at how they're arranged. This is axial section through the forearm. So there's flexor carpi radialis, there's palmaris longus, there's flexor carpi ulnaris, will be on the medial side. Remember that ulnar nerve and artery hiding right underneath flexor carpi ulnaris. So here is the muscle, the single muscle in the intermediate compartment, flexor digitorum superficialis. And as the name implies, flexor digitorum superficialis is going to flex the digits. So it's going to digits 2 through 5. Remember, digit 1 is the thumb. It does not go to the thumb. But it goes to digits 2 through 5. So your index finger through to your pinky. And you can see how it inserts. It has this very unique insertion pattern wherein the tendon is splitting or bifurcating and inserting onto the middle phalanx. So this means, if you think about it, the flexor digitorum superficialis is crossing the wrist, so it can act on the wrist, so it'll be a wrist flexor. It's going to cross this joint. What's the name of this joint, somebody? Good, that's MCP. So MCP, metacarpal here, proximal phalanx there, so this is metacarpophalangeal joint. So it's going to act on the MCP joint. And it's going to act here, the proximal interphalangeal joint, the PIP. Notice what it can't do. So flexor digitorum superficialis cannot act on a dip. It cannot act on the distal interphalangeal joint. The flexor digitorum superficialis is purely innervated by the median nerve, so pure median nerve innervation. So whenever the median nerve enters the forearm from the carpal tunnel, remember it's not the carpal tunnel, from the cubital fossa. So you have the biceps tendon, brachial artery, median nerve. Here's median nerve. It goes under flexor digitorum superficialis, just like this, and it would ride it all the way into the hand. And I can see it right here. So right here in this picture, that's the median nerve riding right underneath flexor digitorum superficialis. And while that's happening, the median nerve will give off a little branch. So here I see median nerve, bottom right here. It'll give off a little branch. This nerve in real life is thread thin. This is literally as thin as a thread. This is called the anterior interosseous nerve. And as the name implies, if you just break down the name, here's the interosseous membrane. Here's the radius, here's the ulna. So the interosseous membrane is between them. You'll see a nerve, little tiny nerve, the anterior interosseous nerve and the anterior interosseous artery running right on their ventral or anterior surface. Okay, these will be important for the muscles in the deep compartment. Okay, so this is the only muscle in the intermediate layer, flexor digitorum superficialis. Quickly, we'll talk about functional hand positions. We'll talk more about the thumb later. So our hands are interesting, as this is part of the reason why man is called man, referring to manual versus pedal or something like that. So our hands are super important. Like, we're known for our hands. We do good work with our hands. And our positioning of muscles in our hands, intrinsic to our hands, can put our joints into extremely physically advantageous positions. So some positions that we're known for, precision grip is one. So while we are pretty powerful with our hands, we can also be quite precise. So like holding a pencil is called a precision grip. We're also able to hook. We hook pretty well. And other animals are better than us at this, like gibbons, or animals who aren't bipedal, or animals who brachiate for a living. They'll swing through trees like this. You guys ever played like the monkey in a barrel game? Yes, all the monkeys are in hooks. They have this hook grip. So we make a pretty good hook grip too. We're not as good as like a gibbon or some of these other guys, but we're pretty good. So if you're grabbing something like a hook, we make a pretty strong hook grip. What we're best known for is this power grip. So power gripping is subtle. It's like hook grip, except for you can see a little bit of extension here at the wrist joint. You see that? So you can feel, like whenever you make a power grip, if I were to say, all right, squeeze your hand as hard as you can, then what's happening is a lot of the muscles I've just mentioned, like flexor digitorum superficialis, the one we're about to mention, flexor digitorum profundus, they're squeezing your digits down, flexing your digits very tightly. Of course, they also cross the wrist joint. So we have to somehow negate its action at the wrist, otherwise we would kind of go into this position, and you can feel it's weaker there. So if I were to say, all right, flex your wrist into the most flexed position you can get it, and then try to make a fist really tight, you can feel it's weak. It's not very physically advantaged there. If you were to extend your wrist a little bit more, then our power increases a lot. And that's because we need the muscles on the backside, which extend the wrist, to neutralize the flexion effect of the muscles which are crossing the wrist joint. So it's like purely digital flexion at that point. And you can feel that. You can feel the muscles on the backside. So as you're flexing these digits down, I can feel on the backside of my arm, of my forearm, that I'm getting some wrist extension as well. So I keep my hand in this neutral position. I don't want it waving around like this. So that's where I'm strongest. We know this intuitively, but anatomically, this is kind of the explanation for it. All right, so just one muscle in the intermediate layer there, flexor digitorum superficialis. So final layer, really quickly, we go through these three. So in the deep compartment of the forearm, there's three muscles. The three muscles in the deep compartment in this picture are illustrated with flexor digitorum superficialis removed. So if I go back, flexor digitorum superficialis is now covering those three deep muscles. So if I were to cut it off the radius like I do in lab, if I were to cut this off the radius and flip it back, I would see something like this. I would see three muscles. The first one here, flexor pollicis longus. Pollicis is the anatomical word referring to your thumb. So your thumb is a pollex and your big toe is a hallux. So flexor pollicis longus. When you hear pollicis, you're thinking thumb. So you can see the flexor pollicis longus muscle coming up like this. It'll pass through the carpal tunnel, and it goes all the way out to the distal phalanx of the thumb. So this means it's going to act on the metacarpophalangeal joint and the interphalangeal joint of the thumb. Okay, so if you're flexing down like this, you can see that. So this person is testing the interphalangeal joint here at the thumb, which means they're testing flexor pollicis longus, which means they could be testing the nerve. And in the case, remember, of the nerves in the deep compartment of the anterior forearm, we're thinking the AIN, or the anterior interosseous nerve, which is a branch of the median. Remember that thread-thin little nerve I saw in the interosseous membrane. All right, two more. So the muscle here most medial, I see a wad of muscle that sits underneath flexor digitorum superficialis. A good name for it, we call this flexor digitorum profundus, profundus meaning deep. So flexor digitorum profundus will pass through its four tendons, like flexor digitorum superficialis will pass through the wrist via the carpal tunnel. And notice the distal insertion pattern here. It's a little bit different than flexor digitorum superficialis. So flexor digitorum profundus will insert onto the distal phalanx. You see that? Notice also it's only inserting on digits 2 through 5, which is similar to flexor digitorum superficialis. Okay? So flexor digitorum profundus then is the only muscle that we have to act on the distal interphalangeal joint inflection. Okay, whereas superficialis, remember, can't act on the dip, it can only act on the pivot. Also innervated by anterior interosseous nerve. And you can see the relationship there. So whenever the flexor digitorum superficialis is coming over, its muscle would kind of attach, its tendon would attach like this, kind of bifurcating on either side. That'd be superficialis. And then profundus, you can see that white tendon would just run between them. It runs under and then pops out between them. And you can see that here. So this is flexor digitorum superficialis tendon. And then profundus is emerging from under it, splitting those tendons into two. And the last muscle is what we call the wristwatch muscle, or pronator quadratus. So pronator quadratus likes to grab the radius and roll it over. So very deep. It's very deep. You can't palpate this or anything. It's way down there. So it's just going to grab that radius and roll it over into pronation, so your palm is facing down. So pronator quadratus is innervated by the anterior interosseous nerve, like flexor digitorum profundus, like flexor pollicis longus. So all three of these in the deep layer innervated by those. How much do we got left? Just a few things. All right, let's just power through these. The next one's only like 24 slides, something like that. So it'll be a little shorter. So anterior forearm is kind of beefy. All right, so synovial sheaths. So we talked about synovial in the context of joints. So we got to keep our joints kind of lubricated. Our tendons that are coming down and entering into our hand, most of them have an association with a synovial sheath. So there's literally a synovial sheath surrounding these tendons that is lubricating them, preventing friction and allowing them to glide smoothly. And all of this is illustrated here in the picture by these little blue parts. So these little synovial sheaths are kind of separating and binding together and allowing lubrication between these tendons. So here I see flexor digitorum profundus tendons. There's these four, the flexor digitorum superficialis tendons. There's, I guess, flexor pollicis longus right here coming up. So all these they're just wrapped up like this. And as they go into the hand, you'll see them buckled down by these little pulleys. They call them fibrous digital sheaths. So these fibrous digital sheaths are buckling down, not just the tendons, but also their synovial sheaths like this. And this essentially keeps them from what we call bowstringing. So if I were to fire the muscles and they weren't buckled down by these fibrous digital sheaths, they would tend to bowstring against the skin. There's nothing to hold them down, acting like a pulley and giving them physical advantage. And the hand surgeons have all this figured out. So they have all these little individual sheaths, A1, A2 pulley, A3 pulley. So they go pretty hard. You can also see this relationship I mentioned, right? There's flexor digitorum superficialis splitting around. There's profundus coming through. Pretty cool. So remember, profundus is the only one acting at the distal interphalangeal joint. And just a bit of a cross section here, so you can see that. So the fibrous digital, that little sheath there, and then the synovial sheath on the inside, tendon running in between. Okay, just a summary of these. So some things I want to point out here. So anterior interosseous nerve. So if I injure anterior interosseous nerve, flexor pollicis longus shot, pronation may be damaged, so pronator quadratus. And then something I want to point out that's unique is the flexor digitorum profundus muscle is dually innervated. So it receives the anterior interosseous nerve on the lateral side, and it receives the ulnar nerve on the medial side. Let's think about that. This is important, so just bear with me here. So flexor digitorum profundus, all the way out to the distal phalanges. I want to flex my fingers down. Definitely got to use profundus to flex at the distal interphalangeal joint. The muscle belly down here has two nerve supplies. The lateral two, which are associated with digits 2 and 3, are innervated by the anterior interosseous nerve. The medial two, which are innervated by the ulnar nerve, digits 4 and 5. Okay, so this muscle is dually innervated. So put a pin in that, so that's clinically consequential in just a second. Blood supply. So the blood supply is pretty straightforward. We mentioned the brachial artery. We mentioned its complicated little collaterals and anastomosis around the elbow. We mentioned the brachial artery splits into the radial, which is lateral. Okay, we felt that radial pulse out here, right? Just lateral to the flexor carpi radialis tendon. And then the ulnar artery, which is medial. The ulnar artery is way bigger than the radial artery. It's a way bigger caliber. And I can see coming off the ulnar artery a small little branch here called the common interosseous. And the common interosseous will give off two small branches I'd like for you to know. The anterior interosseous artery, and running behind the interosseous membrane on the back of the arm, the posterior interosseous artery. So anterior interosseous on the front, posterior interosseous on the back. Very small. We saw anterior interosseous artery running with the nerve right against the interosseous membrane there. Okay. And then both of them enter the hand. So the radial artery and the ulnar artery, they'll enter the hand, and they anastomose with each other twice. Is the two really large anastomoses. They form some more minor arches. But you'll see two primary anastomoses here in the hand. So they essentially anastomose with each other. They'll anastomose with each other. I can see one of those little anastomoses here. So they're coming forward and across. So this is the superficial palatal arterial arch. This is the one you see right here. Okay, so more on that in just a bit. Okay, so a couple of important syndromes to take with you. One is anterior interosseous syndrome. So AIN syndrome, anterior interosseous syndrome, would affect the nerves in the deep anterior compartment, which means what? Which means that flexor pollicis longus is affected, pronator quadratus is affected, and then the lateral half of flexor digitorum profundus is affected. So these two digits here. So a common way that clinicians could test this is by asking them to make like an OK sign. So if you ask them to make an OK sign like this, the one thing that you're asking them to do is to flex the thumb at the interphalangeal joint, and you're also asking them to flex the distal interphalangeal joint of their index finger, right? So this means that you're testing flexor pollicis longus and flexor digitorum profundus to make this OK sign effectively. If they have damage to the anterior interosseous nerve, then their OK sign will be flat like this, almost pinched together, because they can't flex at the IP joint here in the thumb, and they can't flex the dip, they can't flex the distal interphalangeal joint in the index finger. Does that make sense? Anterior interosseous nerve syndrome. All right, and then one other nerve syndrome here is the sign of benediction, or the hand of benediction. So the sign of benediction is an active pathology. You would ask the patient to make a fist. You say, okay, patient, make a fist. And they do this, so they can get these two digits down. So digits 4 and 5 will go down, but digits 2 and 3 will stay up, simulating like this religious symbol of benediction like this. And the reason is because if you damage the median nerve, which is innervating flexor digitorum profundus, right, and flexor digitorum superficialis, proximal to the forearm, then the ulnar nerve is still working. So that means that flexor digitorum profundus on the medial side, so digits 4 and 5, will still work, but these two will not. So when they try to flex and make a fist like this, digits 2 and 3 are busted, digits 4 and 5, because the ulnar nerve is bailing them out, will still flex down. Okay, let's come back at 9.